Today, I will probably take a more macro perspective than the other speaker in the conference, looking at different modes of healthcare reform. And if you're tired, it's end of the day, and just before you get to sleep, one message is that improvement in healthcare depends on a balance between structural change and changing interaction among people. And it's a very difficult and challenging balance to achieve. And the second message, it's not sufficient even if you achieve this balance. You need to deal with broader systemic factors that I will refer to at the end along the political economy of healthcare and healthcare system. So first I will do a brief introduction about what I consider the prospect for transformative change and large-scale improvement in health system. And I will use as an introduction two trends or metaphors that are used or consider as being the next frontier in health policy and management. One is the metaphor of learning health system, and the other one in quotation is the academization of healthcare, like you see in Stockholm, this idea of making academic out primary care. So the expansion of academic mission throughout the healthcare system. And I will just go fast on this and move out of academic health center, but if you look at the report of the task force on academic health center in 2010 in Canada, they insist about the potential, the innovative potential of these new centers. They're supposed to be in a position to accelerate the translation of new knowledge in order to deliver better drugs, better model of care, better practice, better patient experience, and so on. And we get a good dose of this in the current discourse around learning and system. It is seen as entities that will harness the benefit of data and the power of analytics to learn better from patient experience and to use this patient experience to improve care and at a large scale in a system. And when I see title like improving quality in network, it's really about this, is how you use data, how you put people in context to work differently in order to improve care significantly. And strategic clinical network in Alberta is probably one of the examples that is most referred to in Canada as doing this. And then that's the ideal. And then we have the reality of our system. And of course, this is a cartoon, but very often in healthcare reform, and I carry this for 5 years, but unfortunately it's still quite actual. Like we call for, I will use the term reform, but think about big policy shift or discourse around strategy to bring about large-scale improvement. And then we have the discourse, but very often we still organize exactly the same. And that creates a kind of disenchantment, and people get impatient. And as you know, politicians sometimes can be impatient too, so they launch sequence of big reform and reorganizing. Sometimes there is a rationale to do so. Sometimes the rationale is less explicit and so on. And we will come back to this. But this is the message here, which I guess it's the third one. This context is there and will continue for a while. At least in Canada, it's very difficult to think that the broader political context will not impact on our effort to improve care at the delivery level. Like, it's the reality, and not just in Quebec, in Ontario, differently in other provinces. Saskatchewan is there this fall. Nova Scotia was there in 2015, so that's a kind of given in our situation. Another aspect about large-scale transformation and improvement, you have this book by, they are all friends and very dedicated political scientists. They wrote this book, I think, in 2013, and they conclude in a quite desperate way that they call it the paradigm freeze. So even with climate change, it's no much defreezing on this side. And it's a statement about the inertia on the healthcare system. And you get in their conclusion the usual suspect. It's difficult to bring on board physician. We refer here not on individual medical doctor, but more organized medicine and so on, and the way we allocate resources and so on. And this is all true, but at the same time, when you look closely at healthcare system in each province, you feel that the background story is true, but it may not reveal enough about the current effort to improve the system and some good strategies that are put in place around patient partnership, around clinical network, around better use of data to improve care and practice, and so on. So our work is more as a prolongation and elaboration of the conclusion of this book, and I have debated this with them. We're not alone that struggle to improve healthcare system at large scale. Saltman and colleagues who look for the last 35 years at healthcare system in Europe, mostly to the European Observatory on Health System and Policy, conclude that our system have difficulty in being enough reactive and responsive to the evolution of needs and expectation, and it's a challenge, and we have to find a way to accelerate the capacity of our system to adapt. One of the hypotheses, and I'm not saying that it's the only approach, but we have worked in 2011, so not so recently, with the Canadian Foundation of Health Improvement, to try to identify levers that we can mobilize to improve healthcare system. And this is one mapping among other, but you get again the usual suspect. But the 4th and 5th message in this talk is that the 4th one, you will not get significant improvement. You may call it quality improvement. You will not get significant improvement if you just rely on one of these levers, over-investing one lever, like. And I'm not saying in a negative way, but like taking the lean and saying every effort in improving our system will transit through the widespread use of lean like they did in Saskatchewan. It can be good, but it's probably not enough. So the idea is that you need a cocktail that will be different in every province, depending on context, experience, and capacity of clear target related to health need and population health. You need to create supportive policies and incentives. And one of the main challenges when we look at the history of reform across Canada is the difficulty in reallocating resources. Like you can struggle, people like you on the delivery side of the system can struggle indefinitely to improve care, improve primary care, develop network. But if some of the resources don't circulate toward these areas in the system, you will have nice policy objectives, but it will be very difficult to achieve your target. And the proportion of the healthcare budget that are dedicated to what I call area of deficit of care across Canada, like in mental health, home care, and you get variation in province, but you certainly still in a situation that our healthcare system underinvests area that should be prioritized. And that really relates to, in my view, the biggest inertia in our system is not necessarily professional attitude. It's not necessarily that managers don't want to see resources reallocate. It's the overall system that is not equipped to do this well, and I will revisit this when I talk about political economy. And if you look at the bottom of this figure, I think big progress are achieved around building capacity. This idea of we need better data, how we can make it happen. This idea that we need capacity to manage quality improvement and so on. And I think, again, with variation, health system across Canada have paid much more attention than before to these aspects. And we work under the assumption that these transformative or improvement capacity are more distributed and collaborative that we usually recognize or used to recognize. I think the mindset of partly policymaker, but also people like you who work in the day-to-day running the system and delivering care have changed through time. Like we know that what I call real reform, or what we call real reform, depends a lot on these capacity in the system. And you may have the best policy shop in a given government if you don't have investment and support to develop new ways of working. You may think about team-based care. You may think about implementing and developing strategic clinical network and so on. These things don't emerge naturally because you think of it Sunday evening and suddenly Monday they are there. There is a pathways between contemplating doing this and executing properly, and it depends a lot on developing new capacity in the system at a sufficient large scale. And I think a difference, and I'm not talking specifically about Quebec now, but a difference between the way we used to see reform in healthcare, and now it's a growing preoccupation for improvement capacity. There is a big rationale for this, and as this very renowned health economist from York University in England, Alan Menard, mentioned in one of I say his last paper not because it disappeared, but I think he's more in gardening than health economics now. And he suggests that it can be so-called private healthcare, public healthcare. Generally, systems are relatively good to rationalize the utilization of resources, budgetary cutback, constraining resources, and so on. And even in Canada, since the last 5 years, we're not too bad in province to sort of control the progression of costs. It's not our big challenge. The challenge is that there is a big difference between controlling costs versus improving care. And we use in reform to start with costs in the hope that it will shake the system, and then people will shift toward new ways of working, and we will get ultimately better quality. As an example, this system works probably the other way around. It may be good to send strong signal around resources, but you probably need to start with what I call a quality drive, a big quality improvement agenda, and then hope that through this you will eliminate redundancy, inappropriate care, and get a positive impact on the budget with this. So that's sort of the other way around, and it's probably very difficult for politicians to think that way. It's an hypothesis that seems up to now much less accessible than the other way around, and saying we start by budgetary compression, restructuration, and we'll see what's happened in the end. And I say politician and not policymaker because I think many policymakers know this very well, but politicians don't help them implementing this policy in many governments. This brings us to the second part, and I don't know about time, I guess. Is it good, bad? It's not too bad. So this was the introduction. Then let's move about how different provinces play with healthcare reform through time. And I will cover this in 3 minutes. This is restructuration. And I think if you live in some province, it's more familiar for you than in other provinces. Let's put it that way. No need to talk more. With the following remark, sometimes people use it excessively, but the message is not that playing with structure is always detrimental. Sometimes you need to do so. It's a matter of timing and giving the right dose, because sometimes structure need to be reshaped for all sorts of reasons, and I come back to this. But as you know, we can have massive restructuring in some province. And then people became disenchanted with restructuration, so they sort of create a kind of fairy tale around collaboration. So, okay, let's stop restructuration and we will interact positively, collaborate. And one of the empirical signs of this is the relatively large-scale spreading of quality improvement collaborative. And, you know, names can vary, but this idea that you put people together, you develop capacity around quality improvement, you define clear improvement goal, and you orchestrate this, you develop clinical leadership through this, and you know things will evolve and they will improve. And across Canada, we have many nice examples now of collaborative quality improvement, some at a larger scale, like the reduction of antipsychotic use for dementia patients in long-term care is an example. Quebec just signed to be part of this. New Brunswick tried to do this at large scale with some success, and so on. So the sixth message is that despite tumultuous context in some province, despite structural limitation, despite some pattern of interest that not totally support this kind of collaborative mode, you can use this to, I will say, exploit in the positive sense latent capacity in a system and generate improvement. How far it will go in terms of sustainability, spread and scale up, I guess you say in English the jury's still out, but it's enough plausible to not throwing this in the basket because it does not deliver everything. Because, as I said, not a single levers will deliver at the level of our aspiration for health system improvement. What we learn when we look at healthcare reform is that we used to drive reform a lot from the external, like a big plan and everything changed April 1, 2015. This is more from a reform from outside. We know that we should invest more, what I call reform from within, and a stronger commitment to exploit latent capacity for improvement, despite all what you say so well. Growing attention need to be paid to existing bases of mobilization in the system, maybe evidence-informed care, it's very interesting now with the development of artificial intelligence and data analytics. We see a second generation of what would be evidence-informed care, and I think, as evidence-informed there's a lot of potential, but we will need a lot of change at system and organizational and clinical level to benefit from these developments. Patient and citizen engagement, as you know, in the environment of MUHC, for example, patient engagement and in the co-design of care offers a lot. Citizen engagement, I will say that it's very attractive, but our system have a kind of an history that is not so convincing on this side, and we need to find a way to do this better. And again, as you know, intersectoral policies and intervention have not yet delivered enough to improve the health of the population. It's the collaboration between the health system per se and other sectors are important, and we need to do more on this side. And it's not totally distant from what you will discuss when you talk about quality improvement in network, because some of these quality targets will depend on strong intersectoral collaboration. Another aspect that we tend to put, I would say, under the table, we prefer to talk about, and I will take the case of the medical profession because it's probably the more salient in our system. We really like to talk that it's difficult to bring on board physicians around broad organizational goal or system goal for improvement, but we don't pay sufficient attention to bring them on board. And one of my hypotheses around the medical profession, and specifically the one that have a good share of their practice in private clinic, is that there is probably a way to table on this sense of entrepreneurship to renew model of care and get the best of the medical profession and not the worst. I'm not saying we get the worst. I'm saying there is a need to supplement current form of engagement and responsibility by new model of care, and new model of care depend partly on harnessing the potential of professional entrepreneurship. That I will stop there for this, and then we have talked about structure, we have talked about collaboration, we have talked about latent capacities in the system, and province mobilize this capacity in a varying way. And then there is this, I don't know if we see the elephant in the room or the phantom, but what I call the political economy in healthcare. And I go back to this example that if you look at KI data, you will see that the distribution of budget across sector among the province that accept to put their data in the KI machine, you see that budget is relatively stable, like hospital get this, long-term care get this, home care get this, primary care get this. And if you subtract the increase in money that is count in primary care that relate to physician compensation, you get relatively stable figure. Like if we say it's a priority, we should see more money. I'm not saying this because I'm against academic health center. It's not the place to do so. I'm saying this because if we're serious, if we say that, for example, we create this more compact academic health center that would relate strongly with primary care, and this is part of the ambition of the RIS in Quebec, we need to have more resources in these ideas. And you know better than me the epidemiological argument behind this, the argument around multi-chronic morbidity, the argument around high-cost, high-user, and so on. We need to be much more well-equipped with team-based care in this sphere of primary care. And we have difficulty to do this, and we will have to find a way. And probably it's the kind of place that we need a strong will from government. Strong will from government is not always bad. It can be very helpful to bring about major policy shift if it's related to change in the way we allocate resources. And government is the only one in position to do this. You cannot decide tomorrow that to spread your resources specifically because you're not in excess, but we will have to find a way around this. And not all people will like this. That's another aspect. Like that's the aspect of the political economy and healthcare. So that's one thing that I think we learn when we look at in a comparative way on reform, 2 minutes, 55 seconds. So, and one of the other concluding, because I will switch this as a conclusion, and there are more slides, and it's publicly available for free. Another message is that you won't get quality improvement or improvement at large scale if we not combine strong action, what I call at the delivery or operational side, and we talk a lot about this side, and at the more political level, like our dealing with the political contingency. And I will give you an example. It's a live example. Like I got the brilliant or not so brilliant idea to work on medical compensation 2 years ago through a project that was supported by the two physician unions, the Commissaire à la Santé Bien-être, the Association Médicale du Québec, and so on. And we produce a very nuanced report on medical compensation. It's publicly available on the funding agency site, FQRSC. And amazingly, we did not get much conversation with physician union, even if they have approved the project. And the report is very nuanced and go against many stereotypes around medical compensation. So this kind of sensitivity has to change if we want to improve the system. And this is only one example. And I guess more and more we will have to have in our system some conversation that says if we want to improve the delivery side, let's have some solid discussion around, I would say, sensitive issue at the political level. We will have to use structural change to support improvement process, like strategic clinical network in Alberta is an example. By itself, a strategic clinical network is a structural change that has financial dimension, infrastructure, data, and so on. And we will have to think about structural change more as a reinforcement of improvement dynamic than as the first stage to create improvement dynamic. And that refers to the delicate balance that I refer in the introduction between structure and interaction. And more attention, this is not someone who called me. My time is, I guess, finished. It's 30 minutes, so I will conclude. I have 5 minutes, so I will try to fit in this. This is very dangerous to give extra time. So another aspect is the local context, and I will again take the example of medical compensation just to contrast with the difference when you work on local context. We work on this idea that to get improvement, you need rich context to reach practice. It has different labels, like some people talk about clinical governance, some other people will talk with other terms, but team-based care and so on. But you need to work on the context in which professionals work, and then asking the question after, I can use money to help them developing and nurturing these contexts. And this is very difficult to do when you do this at a negotiation table or in some office at the Minister of Health and so on. You need to do this near the delivery where things happen. And I'm the one that thinks that some of the money that compensate professionals need maybe to be more decentralized. Some real systems do it, and it may be through pay for performance. But if you look at the case of Netherlands, they are very courageous now to say the budget. And I'm not saying we should take that route. I'm just saying that playing with money in a very distant way and then trying to fix the operation in another context, you need to create more connection through this at some point. This will be the conclusion. I have narrative of healthcare reform, and this is the research team, and this is very intimidating because the organizer of this conference is like Suzanne Usher, and I direct her PhD thesis, so better to be not too bad, because I will not survive. And I will conclude of this, this is a map of Canada, and as you know, it's a big territory, not enough history, too much geography, but what we refer along the way, it's different mode of reform explicitly. British Columbia is a relatively peaceful province. They are not very agitated by reform. They do things in a kind of smoother way. I'm not saying that it's marvelous. They just invest millions and millions of dollars to increase the morale of physicians in their organization, and they play with this idea of primary care network and so on. Here, Alberta is our test case of the Commission Clare that was suggesting, let's create this kind of hydro-santé, and we will no longer get political interference. I don't think Alberta showed this empirically when you create this kind of quasi-independent shop called Alberta Health Services. But the question, and we don't have the answer, is how much the creation of Alberta Health Services is partly responsible or has represent a favorable context to create the strategic clinical network. Maybe we will have the answer tomorrow. Saskatchewan is an interesting experience too. They start with lean, they get very excited, as you know, about it, and probably it has started to deliver some dividend on the system, but then political crisis shift gear, and then they are more in restructuration now, at least last news. We'll see. Manitoba, again, like BC, no much noise, working on primary care network, and we have debate now with people in Alberta. They say, it's tough in Alberta, but because we have the option of you get elected by promising doing nothing. And and this is, again, this is not a judgment on them. This is just an analytical viewpoint. And then Ontario, we often idealize Ontario when you're in Quebec, and I have debate with Suzanne on this. And more we go deeper on Ontario, and we close now, so it's more broad caricature and take it more as a humoristic statement. But what we get from Ontario is less restructuring, and I will put some nuance in this, but less restructuring since early 2000, end of the 90s, working on developing accountability relation in the system, then having this excellence for care for all act and patient first. So more working around this, what we have called the emergence of a quality drive in health policy in Ontario. The challenge is good idea, bright mind, maybe difficulty in execution. And part of the current restructuration around LINS aim at creating a more integrative governance structure that will deliver around these aspirations. But, it's not necessarily an ideal case. Then Quebec, we're so happy to be in Quebec. Everything is perfect. We can recover from massive restructuration, have a relatively good moral. Well, data on human resources don't show this, but suppose that people take some break sometime, but they go back to work after. And to be serious, when you talk to some executive CEO of CCS these days, probably mostly outside Montreal, I should say this, some of them told us, it was tough. Of course, the manner can be different, but it's difficult. Some manner you should learn at kindergarten, but when you skip your kindergarten, you're killed. And they say we start to see some benefit of having created this large regional integrated system, because we can call it that way, that internalized previous planning coordination function from regional authority with the delivery side. And I did some archaeological work. And one of the people who has asked this, and it's bad that Lise is not here tonight, like we like to discuss this, is that the ACAIS, in a report on governance in the system, have said maybe regional authority is redundant. It's always enough centralized. Then the Castonguay report of 2008 say we need more clear accountability line in the system. And at that time, the association of manager in the system and CEO were very local in saying, yes, let's fix the governance, let's go. And I think we have a situation that is not totally just a political creation. But we can discuss this around a glass of wine. So, and then I would close with the Nova Scotia province, which is a major restructuration, April 2015, creating a 4-district zone and a central authority. And what we can learn maybe from Nova Scotia is that, and of course there is the issue of scale. Scale is everywhere in what we discuss. It's different doing something in Quebec and Ontario than Nova Scotia, than British Columbia in a sense. But they pay a lot of attention to prepare the transition toward the new ways of organizing things. Maybe in Quebec we did differently, but I'm not sure. Thank you.